I think this has really sort of increased the perception of the patient that this is a skilled worker. I mean, even earlier, they would come in uniform, they would use the technology platform, etc. But I think the fact that they can now do diagnostics independently has really changed their own confidence, but also the perception of patients as to the quality and caliber of the care team that they are dealing with. Batch, we had a bunch of practical considerations that I would say the Ajma team has been very kind to incorporate into the design. For one, all our workers, live in Satara. They have to be trained where they are, right? We could not bring them to Bangalore for classroom sessions, etc. Second, as the employer, I cannot afford for them to be sitting in classrooms for weeks at a time. Many of them learn on the field, are actively sort of working. So the training had to be as much as possible a combination of field, some classroom, of course, and a lot of self-learning delivered by our learning management type solution. We wanted a lot of focus on technical skills, phlebotomy, suturing, handling a portable ECG machine, doing imaging of oral lesions, how to do motivational interviewing for patients who are struggling with adherence issues, keeping patient health record updated after every visit, recognizing red flags, etc. Right? So the focus had to be very clearly on that. And the request was to keep theory, medical terminology, which often just because of the language becomes a huge barrier. Many advantages for us, including not the least, deepening the culture of supportive supervision that characterizes the relationship between physicians and care team. And I think by co-opting the physicians into the supervision, I think it really sort of deepens that culture of team-based care. I would say the most important area where the diploma has had an impact on us as an organization, on our health workers, is on diagnostics. Many of you know this. There are very few DMLTs available at the block headquarters and below. So previously, what we do is we do point of care testing, such as an RBS or a POC A1C device, etc., and then prescribe other investigations to be done at local labs. However, as you can imagine, there was significant loss to follow up on all of these, including pretty high-risk patients. Our health workers now do the sample collection, thanks to the training, as part of the existing interaction. So same visit, you kind of get to do more, you get more value for money, and then send the same to our partner labs. And very importantly, we find that patients are more than willing to pay for this convenience of sample collection at home. And that's really something that's facilitated. When we looked at what was out there, however, there was really no formal training or certification available for health workers. In fact, to get a phlebotomy capability, you need a minimum of a 6-month classroom session, which is simply not practical, right, in contexts like ours. So this is when we turned to IHMR and found a lot of alignment with them. And of course, they have wonderful experience, as was shared. Finally, I will just say in terms of there may be interest in terms of costs, etc. The first batch we sponsored for all 11 workers, we sponsored the cost of the diploma. Going forward, we are very keen to test out some cost recovery models so that it's also seen very much as part of the professional kind of certification journey. At rupees 35,000 per health worker for the diploma, we think this can be easily recovered over a 12 to 15 month period from salary. So I think that gives it much more scalability.